Welcome to the final Echo series or the final Echo for our Toqq-Rcc series with Dr. Wolf Birchfield. Today, we are so excited to have Jennifer Hines, a physician assistant with KU Medical Center, to address some of these education issues we have with monitoring toxicity and management for our patients who are on IO and TKI immunotherapy regimens for RCC. So we are super excited to have you here today, Jennifer, and we're excited to have get your special perspective on helping these patients. So we'll go through a few housekeeping slides real quick, just our agenda and who we are and what we'll be doing today. We do offer, this is our conflict of interest disclosure for your review, and in the event that you need a little more time with it, just reach out to me. I'm happy to provide it for you. We do offer continuing education credits for participation in this Echo series, and it's important that you remember to sign in first and last name and your email address into the Zoom chat box in order to get those credits. This is our statement for today's session, and just a reminder that we do offer certificates of attendance in the event that you're not interested in getting an actual CEU. The code for today's CEs is 72 TORN. The deadline is Thursday, August 19th. You can text that code to this number here, go to eads.com, or download their app and enter it that way as well.
It does look like it's 27 TORN.
Yes, 27 TORN. Mm-hmm. That's correct. Were you wondering if it was correct, Libby? Yes, it's correct.
No. We're good, thanks.
Okay. This project was funded by a Pfizer independent grant for learning and change, and of course wouldn't be possible without the additional support from the KU Cancer Center and the Masonic Cancer Alliance. We do record these sessions for quality improvement purposes and also as part of our enduring materials so that people can revisit this information later on. We do upload these videos and the slide decks to the telementoring page on the Masonic Cancer Alliance website. And the last slide has a little link of that for you. We are all Zoom experts at this point, so just remember to keep yourself muted when you're not speaking. Speak clearly when you do. Utilize the chat box. We have plenty of people that are looking over that to help us make sure we're not missing anybody's questions or comments. And then when you do turn your camera on, make sure we can see your face, because that's the best part of you, right? We also do polling questions. Those questions will just pop up on your screen. You get to choose your answer, and then we get to look at the real-time results. And I believe we have one poll question today. So I'm going to pause my screen here for just a minute, and we're going to welcome our friends and see if there's anybody. Is there anybody on the call today that has not attended one previously? Annie's a familiar face. Faith, I don't know if Faith has joined us before. Faith, would you like to say hello?
Hi. I have not joined. This is my first time.
Okay.
Hi, I'm Faith. I'm a research coordinator that works with Dr. Wolf Birchfield and also Jennifer.
Oh, wonderful. Good. Well, it's very nice to meet you. We're glad that you joined us today. Catherine Davis. I can't remember. I feel like I would remember another Catherine with a C, but I don't remember if you've joined us before. Are you able to say hello?
She usually doesn't have a microphone, but she is a clinical nurse coordinator with the KU GU oncology team.
And she has joined us before, and I feel like I've done this at every Echo when she joined us.
I think it's just because she doesn't, unfortunately, have a setup on Fridays in which you can see her face. And so I'm sure if you could see her face, you would remember her. It's always so much easier that way.
Well, she's just going to be a special memory for me in the Toqq-Rcc series for sure. And actually, Jennifer, I feel like your face is super familiar to me. You've been around for a while. We know each other, don't we? Oh,
yeah.
I'm sorry.
That's okay. I think you used to schedule here before you transferred to.
I did. Yes, and then I did all the genetic testing and counseling with Dr. Klemp. That's so funny. I'm so glad to see you.
Yeah.
It's so nice.
Nice to see you.
Nice. Let's see. We have. I know we've got some. If you're really inclined to say hello, we have a moment to do that. But so many of you are familiar faces at this point. Annie, we're happy to see you again. And Denise Whitcop. I don't remember if you've joined us before, but your last name is unfamiliar to me. Would you like to say hello?
Hello, everyone. I think I've attended all of the previous sessions. I've enjoyed them very much.
Good. Well, we're glad you're here today, Denise. Okay, well, I'm so happy that you all are here, and we'll get back to why we are here, which is to learn. So just a couple of reminders. Well, first of all, our learning objective today is to really discuss the delineation of roles among the oncology care team regarding the comprehensive patient and education of these patients, which is where Jennifer's expertise is going to be really helpful. We do work very hard to protect patient privacy. Our case presentations are cases that are probably inspired by patients, but we're not using any real photos or names of those patients. With that said, I'm going to hand it over to Dr. Wolf Birchfield to get us going today.
Worsened over several months and made it more difficult to bend over to work in her garden. So she did undergo workup for this. And because she had back pain, she ended up having a CT of her spine, but it showed this kidney mass. And she ultimately had staging, didn't have metastatic disease, and had a nephrectomy. So she started on a surveillance program thereafter, after being diagnosed with stage 3 kidney cancer, and ended up having multiple lung nodules. She didn't have other sites of disease. She had favorable risk cancer. And she met with medical oncology, and they decided to embark on treatment with axitinib and pembrolizumab. So for some of the, as several of you may remember, knowing that you've been able to participate in other parts of the series with us, this is one tyrosine kinase inhibitor, which is the axitinib, and pembrolizumab is a form of immunotherapy. Miss Z ended up developing painless growth hematuria and sought care in the ER because she was worried she had a kidney stone. They worked her up for that, but it didn't show a kidney stone, but did show a kidney mass, as well as some tumor thrombus and multiple lung nodules. She ended up undergoing a biopsy that showed clear cell renal cell carcinoma, and that also proved her stage as stage 4 kidney cancer. Her IMDC risk score was intermediate because of her de novo metastatic disease. So she met with her medical oncologist, and they decided to do treatment with 2 immune therapy medicines. So when we look at these 2 women, they have slightly different presentations and got slightly different treatments for reasons that they decided with their oncologist, but they both want to be aggressive with their care. So the focus of today's series is really about how do we prepare these patients to undergo these treatments. And so we can go to the next slide. And what's the best way to educate them so that we can we can promote safety, we can ensure that they are prepared and facilitate their coping with their treatments. So first, I will want to start off with a poll, just because those of you who may be clinicians or interact with patients in any capacity who might be starting a treatment that's a combination of 2 different medicines, whether it's for kidney cancer or any treatment really, because most of these principles will apply to some other types of treatment as well. When you think about what concerns you might have, whether it be a patient, whether it be a loved one, if they're embarking on a treatment that has multiple medicines in it, what would be your primary concern? Would it be that the patient might just be more overwhelmed, or uncertainty about how to determine what their side effects are coming from since they're on 2 different medicines? Would it be worry about them being able to adhere to the treatment regimen, or just financial toxicity? And certainly we all would be worried about side effects, but I'd love to hear what worries or angst some of you might have if you were a part of someone's life, whether personally or professionally, and they were going to be starting on a combination. Just letting some of the responses roll in real quick. We really do need some hold music. We talked about this in the past. Okay, well, I think we have some good responses.
You could sing.
Well, I think, my view may be different from everyone's. Can everyone see the poll results now? Okay, so it looks like there's concern about all of these things. Worry about financial burden for patients, worry about how we're going to know what side effects come from what, and therefore how to make them better. Worry about how they're going to stick to their treatment and whether they'll just feel overwhelmed. These are all concerns that we have when working with folks or being a part of their lives if they're undergoing this treatment. And guess what? Patients are worried about this too. So part of their education will empower them. And so that's why we want to talk about some strategies today. So when starting out and thinking about patient education, a lot of times in the setting of patients starting a systemic treatment for cancer, what's the ultimate underpinning of all of this education, at least in most oncology practices, revolves around the informed consent process. Typically, patients certainly can educate themselves and can be educated in other settings, of course. But what we're specifically going to be talking about today when we talk about education is going to be about how we effectively will do these counseling visits to prepare patients well. And I'm so sorry, I'm going to have to switch over my audio to computer. Just give me 1 second. Let's see. Well, I guess I'll do that in just a second if it gives me trouble. So when we think about informed consent, the basis of this is really an ethics. We're asking patients to trust us with their medical decisions. And in order to do that, the ethical framework in most developed countries, including ours, is that we want to make sure that the patients are making the medical decisions themselves in line with their own values and making sure that we're respecting them as an autonomous person and their own human rights, rights to dignity and things like that. So the consent part is easy when it comes to cancer because patients are often frightened and they're willing to give us their permission so that we can do treatment, but really informing them in an effective way, that's harder. That's a little bit of a different animal. So in addition to, making sure that we're following ethical boundaries, informed consent promotes safety because we educate them and their support people about what the treatment effects are, how to adhere to the treatment. And we also set expectations so that they can be prepared for what's coming and they can have a mental and emotional, sometimes spiritual framework to cope with that. So the way that these discussions are conducted will depend on the individual patient factors, of course. But just depending on what their education is, how well they speak English, what form of materials they benefit from the most, do they rely on written materials or do they benefit most from the discussion, et cetera. But when thinking about this specific for kidney cancer or a circumstance in which patients are getting treatments that have two totally different mechanisms of action like this, it is important to try and draw a distinction between what the way that the expectations we have for one treatment, the expectations we have for the other treatment, and how those differ. So an example of this, and this is from a great talk that was given by Dr. Betsy Plimick, and from her slide there, thinking about how do immunotherapy risks and side effects differ from those from these tyrosine kinase inhibitors, and some of the things that we would ideally want to communicate to patients about this experience. So when it comes to immunotherapy, we would want to emphasize that immunotherapy side effects are not guaranteed, and there's some unpredictability there. We want to emphasize that this is not related to the dose that they've received. So if we go up or down on the dose, that is not going to change their side effects. That they can happen anytime, that they, as again, this unpredictable nature of immunotherapy, and also that they are not naturally going to go away or heal. That's a big difference from some of these other side effects. And while I don't have, this slide doesn't focus on cytotoxic chemotherapy, these distinctions are extremely important if we're counseling someone, let's say, with bladder cancer, with getting cytotoxic chemotherapy, lung cancer, breast cancer, et cetera, to draw a distinction with cytotoxic chemotherapy, which is a little bit more similar to these tyrosine kinase inhibitors. So with the tyrosine kinase inhibitors, it's important that we would generally want to communicate that these side effects you will have some side effects, that they are in fact dose dependent, that they will emerge early usually, and that they will get better if we hold the drug or decrease the dose of the drug. And so those are important things because we want to make sure patients understand that these are different entities, they behave differently. We expect them or the experience to be a little bit different from each piece of the puzzle, but that side effects are modifiable, but the way that we do that will depend on what sort of treatment it is. So this is another way to look at it, to kind of look at, even though in the prior slide, we're sort of drawing a distinction between some of the experiences that we expect to come out of these two classes of medicine, here we're showing that there are some commonalities here, and we can attribute some side effects in a pretty confident way to tyrosine kinase inhibitors versus immunotherapy. However, there is going to be some middle ground that is harder to determine. And so I think part of our job on the clinical side, again, we want to make sure patients are as educated as possible and as prepared for their treatment. But the fact that there is so much overlap means that a lot of the workup and management of side effects is going to depend on patients first telling us that they have the side effects, because it's not always going to be clear cut. If they have a rash, we are going to need to know and or see that rash to figure out what is the pattern? What do we need to do to make that better? Or what workup do they need? Same things with elevated liver tests, et cetera. So I think in showing that there is this overlap here, it just really drives home the idea that we want patients to understand what they can control and what they should expect, but also to know that there is going to be middle ground and overlap, or at least there's a risk of that, and that we need to be part of the determination about whether something's important or serious. And it's not something they can just do all by themselves. And when we think about general best practices, I think generally speaking, there's not a perfect way to do this. There just isn't. People have different needs, different preferences. So trying to understand the way that patients get the most out of a conversation, it can be hard at the beginning of a relationship. So if you're starting this at the same time that you're meeting them for the first time, this is tricky. But I think the more you can ask them about how they learn best, what they need, how they think they will, basically what their educational needs are, the better job we can do at preparing them. I certainly think that a best practice is to encourage participation of a family member or a loved one or support person in these conversations, because it is rare that patients are able to kind of toggle between this emotional headspace and the cognitive headspace well enough to really, again, cope with what they're hearing, but also grasp what they're hearing. So definitely want to encourage that whenever possible. I know that's been tricky throughout the pandemic, and hopefully as things improve in the future, this will be more feasible. Technology makes a big difference. And even if there are visitor restrictions, just calling that family member, that loved one, that neighbor, that significant other on the phone, again, even if they can't be there in person.
Looks like we lost you for a second there, Libby. We'll give you a minute to get back on. Jennifer, is there anything you would like to add on to this? Did we lose Jennifer too? Looks like we may have lost both of them. Oh, I see you now, Libby. We'll just give her a second to get caught. It's okay. No, we lost both of you guys, but you're back. Yay.
I am sorry. Zoom has conspired against us. I have no idea what happened. It just kicked me off and it disappeared. Anyway.
Well, it may have been a system glitch, because I think that happened to Jennifer too. So you're good.
Oh, bizarre.
Well,
the last point I was going to make here was that I definitely think that while patients may not always have perfect insight into their own sort of educational needs, we in our group have made the determination that we are going to give every patient a verbal counseling session as well as paper handouts and sometimes even electronic handouts about their treatments as well. And our typical practice is that since we are fortunate enough to partner with Jennifer, who has such expertise in patient counseling, I will typically see the patient first, and then we will at that juncture provide written materials, either on paper, electronically, or both, in order to give patients some time to peruse them if they wish and they feel comfortable prior to the actual treatment counseling visit. We find that really promotes patients are much more comfortable if they have at least the opportunity to do some self-education and self-learning. Not everybody wishes to do that, but if we provide it to them, we think it's really it's very patient-centered. And also, even if the patient doesn't want to read it, their family member might. So I do want to pass the mic over to Jennifer now to talk about some pearls and just sort of practices that she uses when doing initial treatment education and counseling. Thank you, Jennifer.
Yeah, thanks, Dr. Wolf-Birchfield. So yeah, we have found it very helpful in our practice if patients are provided the information ahead of time so that they can hopefully look it over before their education appointment. For our practice, the education appointments are in the range of 30 to 60 minutes. And so as you're aware, there's a lot of potential side effects from the medications that we use. And so during these visits, we really do just try and focus on what the most common potential side effects related to the treatment are, as well as some of the more concerning or even potentially dangerous side effects that can happen with the treatment. And so when discussing the potential side effects, we really try and focus the patient as well as the caregiver's attention on the symptoms that they may experience. We try and discuss things that they can do to try and prevent some of the possible side effects, and then also try and facilitate coping throughout the course of treatment. And so if a patient's just on a TKI, really the things that we focus on would be fatigue, diarrhea, hand-foot syndrome, and then high blood pressure. If we're pairing the TKI with immunotherapy, there is, again, as Dr. Wolf-Birchfield previously said, some overlap. And so there we focus on some of the skin changes that can happen, as well as the risk of diarrhea that can be associated with those medications. If the patient is just on immunotherapy, I really, when I educate patients, I think of four broad categories of potential side effects, and that would be the general side effect of fatigue, also the side effect of skin changes or rash, GI side effects, so that would be diarrhea, and then pulmonary side effects, which would be dyspnea or cough. And if patients are taking two types of immunotherapy, again, primarily we discuss like diarrhea and fatigue because those are some of the more common side effects that we may see. And so really, again, when doing education on the next slide, prevention is key. And we unfortunately can't prevent every side effect, but those that we can prevent, we do need to be proactive and try and nip them in the bud before they start. And I believe Dr. Wolf-Birchfield and Grace Martin, our pharmacists, discussed at the last ECHO session about things that we can do, but just briefly to review, some things that we might do with TKIs to help prevent side effects would be have patients start applying a moisturizer to their palms of the hands and the soles of the feet twice a day. We also ask them to get a 10% urea cream, like Utterly Smooth is a brand that has a 10% urea cream or lotion, and have them start applying that to any calloused areas that might develop on the palms of their hands or soles of their feet, because that's a very common side effect from these targeted therapies that we use. I pretty much also educate or ask every patient to get a blood pressure cuff or to make sure they have access to a blood pressure cuff, and to start checking their blood pressure several times a week. And when I'm doing the education, I ask patients to keep a log of their blood pressure readings, send us the readings once a week if they can, ideally via patient portal or a phone call, but also to bring their blood pressure cuff into the appointment at least once so that we can confirm its accuracy. So what I ask patients to do is, our medical assistant will room the patient and check their blood pressure. And then I ask them to check their blood pressure with their home cuff at least once so that we can make sure that their home cuff is fairly accurate. If there's a large discrepancy between the two cuffs and their blood pressure is always normal at home, but here it's always high, then maybe we need to see, is the blood pressure cuff, really accurate at home, and how much stock should we take in those home readings? So bringing in the blood pressure cuff at least once I found helpful. The other thing is having a bottle of Imodium at hand, at home on hand, just in case they do develop diarrhea, so that they can take it if need be. And I educate patients, that prescription strength Imodium, while it's the over-the-counter tabs, it's 2 tablets after your first loose stool and 1 tablet after each subsequent loose stool. The other important thing during these education appointments is that I always stress the importance of communication. And so really, sometimes I summarize things up and, tell patients that we've talked about a lot of different side effects from the treatment. And I always tell patients, if there's one thing that they remember from the appointment, is that if anything ever comes up, they need to call us, and they can't ever, or call us or message us, and they can't ever go wrong with that. If a patient has a severe symptom, they need to call immediately. But if it's a more mild or moderate symptom, that, if they have a loose stool and they have loose stools that persist for 24 or 48 hours, or it's getting worse, that would be, something to call us about. But it's really not their job to figure out what to do about any symptoms that they are having, but it's their job to just observe and communicate and tell us what's going on, so that the medical team can make the decision as to what needs to be done. Again, it's all about patient safety. And so we just, stress that it is important for them to communicate with us. There's different ways that they can communicate, and they can do it through a phone call, patient portal. And ideally, if it's not emergent, it should be handled by the primary team, so the nurse, the APP, the physician, instead of the on-call physician, unless it is emergent.
Thank you so much. Oh, sorry, Jennifer, go on.
Oh, yeah. And the other thing, just with regards to communication, is that we do need to educate them up front that they're not putting their own treatment at risk by communicating with us, but just really that it allows symptoms to be addressed as soon as possible before they get to the point of where the symptoms get too bad, and it would eventually put their treatment at risk. And so some patients are a little hesitant to contact us because they don't want to have to hold their treatment. But if we can address it early, I think that's really in the patient's best interest in the long term. And Dr. Wolf Birchfield kind of alluded to this previously, but we do have some patients who are on immunotherapy and have previously had cytotoxic chemotherapy. And with chemotherapy, with different cycles of the treatment, you kind of think of the side effects as waxing and waning. That's not how it works with TKIs and immunotherapy. TKI and immunotherapy side effects don't generally resolve on their own without some sort of intervention. So for TKIs, it's holding the medication and considering a dose reduction. In immunotherapy, it's typically given steroids. And so again, patients will sometimes say, oh, I'm just going to tough it out. I've had chemo before. It's going to pass on its own. And again, that's not generally the case for these sorts of medications that we're talking about today.
Thank you so much. So to summarize, we think that best practices include having a discussion, but if at all possible, giving them written material, either paper, electronically, or both, before they would be having the discussion about the informed consent, trying to have support people there for patients so that they can also hear some of the treatment discussion, counseling and discussion. Try and prepare them for common ones and arm them with knowledge about how to prevent those that are preventable, and certainly emphasize the essential nature of communicating about side effects. And I did love the way Jennifer emphasized the idea that we wanted patients to know that we're not trying to take their treatment away from them. We're trying to make sure they can be on it as continuously at as most effective of doses as possible. And part of that is acting early to manage any symptoms so that they don't get in a way. In some ways, that's really the lesson of palliative medicine in the oncology sphere as well, one of many, but because if we manage symptoms better, then patients are often able to be on their treatment more. We're not trying to change the care plan. We're trying to promote it and facilitate it. So thanks again so much. We're going to check back with her in just a few minutes and thinking about some of the more practical aspects of workup and management. But if we go back to our case study here with Ms. Y and Ms. Z. So Ms. Y starts her tyrosine kinase inhibitor and immunotherapy, the axitinib and pembrolizumab. And after about 3 weeks into treatment, she starts to notice some loose stools. So she first starts by having a couple per day. Normally she was like a once a day regular type person. And then it increases to 8 stools a day over the course of a week. And she's having some cramping. She's not having any bleeding. She's not having other GI symptoms. And with Ms. Z, she also starts her nivolumab and ipilimumab, which are both immune therapy medicines. She does not have a tyrosine kinase inhibitor. So she doesn't have any symptoms during the first cycle. She's one of those folks that says, like, I wonder if they really gave me the treatment because I didn't feel anything. And then starts to realize she did really get it because she gets a little bit of a rash on her arms. She ends up doing well with some cream there. But then after cycle 3, she really starts to notice diarrhea that really just kind of happens out of the blue. At first, she thought maybe it was something she ate because she started having 3 stools per day and followed by 9 the next day. And then she starts having, producing some mucus there. And she decided that ultimately it seems to be something to report. So given the treatments that these patients are receiving, because the treatments are different, in some ways we need to approach their symptoms a little bit differently, even though what they're having is diarrhea about 8 or 9 times per day. So I wanted to look at some of those nuances and talk some about general principles for how we look at attribution. So getting back to this other great diagram, that's again by Dr. Betsy Plimick. There is substantial overlap for some very common effects from tyrosine kinase inhibitors and immunotherapy. So skin changes, diarrhea, liver test abnormalities, altered mental status. Ultimately, sometimes the cause can be similar, but or sometimes the presentation can be similar, but the cause is very, very different. And because the cause is different, we have to treat this differently, because if we take the same approach, then that's ultimately not going to be successful. And so when we look at, we know that when we're attributing symptoms so that if we know what it's from, then we know what to do. There's going to be some that really clearly have only one possible etiology. For example, hand-foot skin reaction, which we talked about in presentation with Dr. Martin, that really cannot come from immunotherapy. It has never been reported. And so we can be pretty sure what that's from if somebody gets that while they're on a tyrosine kinase inhibitor, even if they're also on an immune therapy medicine. However, the things like in that center part of the Venn diagram, there can be a lot of confusion about what is causing what. So we need to investigate it. Sometimes that will be with testing, labs or imaging. Sometimes it's just going to be clinical investigation where we are evaluating the patient, where we're getting more of the history in order to try and figure out what pattern this seems to follow. And so part of what both of these patients need is more investigation as to what is happening in their cases. So generally speaking, if someone is on a tyrosine kinase inhibitor and an immune therapy medicine, a lot of times the way to approach this will depend on the nature of the symptom, as well as how severe it is at the time you're hearing about it as a clinician. So sometimes if someone has a mild and low risk symptom, it's either mild or it's a moderate in severity symptom, but that is at low risk for causing any significant clinical harm or clinical change, then a lot of times we can treat it as if it is a tyrosine kinase inhibitor related symptom, and for a time limited trial. Just start out by saying, let's go ahead and treat this presumptively as if it is a tyrosine kinase inhibitor, and we'll see how it responds to that treatment and then determine further from there. Now, hold in the setting of which patients either do not have response to treating something symptomatically as if it's a tyrosine kinase inhibitor related symptom, or there's just confusion about the underlying cause of it. Holding the tyrosine kinase inhibitor should be an early strategy that we employ because it can give us so much information. Certainly if someone is having diarrhea and we are able to simply hold their TKI, like in the case of Ms. Y, her axitinib, and it goes away, well, then we've pretty clearly identified what the cause was. And not only have we done that, we've made it better. So that is a key strategy. That's the second of 3 strategies that we try to employ. And then finally, if something is severe or it's a high risk symptom that we think could make the patient very ill very quickly, then we often will immediately treat that as immune related from the beginning. So that's kind of like at a very, very high level, the way that we might approach this. So basically, if it's mild or it's medium, but it's low risk, treat it according to the package insert as if it's a tyrosine kinase inhibitor related symptom. But if it either persists or they just need, or it's severe enough that we need to give them a treatment break, it's okay to do that from the beginning, and it will tell you quite a lot. But if it's severe or it's a high risk symptom, then we'll often have to just treat empirically for an immune related side effect at the start, just to keep the patient safe. Now, during immune therapy, treatment of toxicity, if they're not on another class of medicine, unless they're experiencing a normal life event for people, like getting food poisoning or getting a cold or a sinus infection, that unfortunately their cancer has not gotten them out of those things. It feels like it should, but that we don't get out of, normal misery card if someone gets cancer. It's going to be key to treat it as if it is an immune related side effect. But what's key in this setting is grading. So there is a formal grading system that we turn to regularly without fail, every patient, every time, called the CTCAE. This is used in trials and guidelines. It is such an extensive resource that it's not something I'd recommend you probably print and keep at your desk, because that would kill a few redwoods in the process. But generally speaking, it's something that's good to have saved in the favorites on a browser, on the computer at your workstation, or on your phone. I do think that there sometimes are the National Cancer Institute provides some apps that have this for free. Every symptom, every lab abnormality that could happen to a human being while they're on cancer treatment is going to be here. So this has unique criteria that are specific for every single diagnosis, but in general, it ranges from 1 to 5. 1 is mild, 2 is medium, 3 is medium to severe, 4 is severe, and 5 is death. Typically, grade 4 means that the person is needing to be hospitalized or something very close to that. So generally speaking, getting familiar with this, getting comfortable for just referring back to that time after time will serve you well in treating patients with immunotherapy or participating in their care in any way, because it is central to our guidelines. There are several societies that have joined forces in order to come up with extensive guidelines for treating immune-related side effects for patients who are on cancer treatment, immune therapy for cancer. So the American Society of Clinical Oncology, the Society for Immunotherapy Treatment of Cancer, and the National Comprehensive Cancer Center Network have come together to form a set of guidelines. You can reach these in multiple ways, so you do not have to sign up for NCCN guideline access. However, we do tend to, generally speaking, we just kind of love that because it has some really great flow charts that are very easy to read, simple, clear. And NCCN guideline access is free. So you don't have to pay a membership or anything like that. But honestly, the way to approach toxicity during treatment with single agent immunotherapy or 2 immunotherapy medicines is going to be grade that symptom with the CTCAE and then get yourself to those guidelines to figure out what they need at that time. Don't reinvent the wheel. It's all there. We just have to follow it. The experts have told us what to do. So those are the strategies. Now I did want to just show briefly how you would get there, because it's not always the most apparent. So NCCN guidelines, if you choose to access this information through this mechanism, you go to the guidelines page and go to the supportive care dropdown. And then under supportive care, there are lots of great guidelines for everything from managing nausea and vomiting, palliative care, managing pain, fatigue, distress, etc. But this management of immunotherapy related toxicities is right there and at your fingertips. I did want to just review that. And again, I want to acknowledge that this is from Dr. Betsy Plemick. So when we think about common reasons for holding treatment, it does differ somewhat between the treatments. And as you see here, it's pretty interesting actually to see that for the tyrosine kinase inhibitors, things that are predictable common toxicities, that is the reason that it gets held temporarily, right? Diarrhea, skin reaction, they're tired, they're having some mild liver test abnormalities. That's why it would be temporarily held. Whereas for immunotherapy, it's actually for these less well understood in the moment type things. Like we don't know where the side effect is coming from, or it's a clear immune related toxicity that's causing some hormonal imbalances that we can manage, get back under control, and then supplement the hormones ultimately. Now, on the next slide, when we look at reasons for permanently discontinuing treatment, they again are very different indeed. So for immunotherapy, certainly neurotoxicity is not going to be something that we can chance by retrialing the patient on that. Pneumonitis, refractory colitis, and myocarditis. So what we're seeing here, I just find it interesting. If you see before, the things that we're holding temporarily for are these sort of questions or things that we know we can kind of circle back for. But what we're holding it for are these these serious toxicities. A patient is not going to be able to determine when their immune therapy needs to be held. And that's why Jennifer's strategy of emphasizing communication above all things, so that we who have this knowledge can take their responsibility for making this determination. That's what keeps them safe, because this list of things that lead to immunotherapy being discontinued is not something they can prevent themselves, not something they can assess themselves, not something they can manage themselves. And looking at the tyrosine kinase inhibitors, the things that result in permanent discontinuation are often different than what relates to a temporary hold. So what that tells us is that we can manage those other issues. We can manage their diarrhea. We can manage their skin changes. We can control those things. And that's, again, another reason why her emphasis on early communication is everything, because this data tells us that if we just get their symptoms under control, we won't have to permanently discontinue their tyrosine kinase inhibitor. It's such an important clinical pearl. So in any case, unfortunately, some of these things are just not preventable with tyrosine kinase inhibitors. For example, if people have non-healing wounds, because these are affecting the blood vessel growth of blood vessels, that isn't going to be something that we can really modify. But in any case, I wanted to share this with you and relate that back to our initial education of patients. I think next, I wanted to, again, throw it back to Jennifer a little bit just to talk through the more nitty-gritty of how exactly she approaches this juncture of having a symptom that could be either from a tyrosine kinase inhibitor or from immune therapy, and how exactly she reasons through that. And then a few other clinical pearls about the management of some of these symptoms once she's already done her education of patients.
Yeah, so thanks, Libby. So if we have a patient who's on combination of a TKI and immunotherapy, and they contact us with some mild low-grade symptoms, so they would probably be grade 1 symptoms, let's just say diarrhea or a rash, we would probably continue with the TKI initially and start treating their symptom that they are contacting with us. So again, if let's say they're just having a slight increase in loose stools, so maybe 2 to 3 loose stools a day, that would be considered grade 1 diarrhea. They may need some IV fluids if they're not able to keep things down, but we would continue the TKI, have them start an anti-diarrheal during this time, as we talked about previously, and then monitor their symptoms closely for probably like 48 to 72 hours and see how they do. There are some patients, as Dr. Wolf Birchfield mentioned previously, that are treated similarly regardless of the underlying cause. So if we're seeing a patient in clinic and they have some hypothyroidism, both the TKI and immunotherapy can cause hypothyroidism, and we would still continue with the therapy while starting them on thyroid replacement medication. Or let's say a patient has a low-grade rash, or maybe they just have some increased fatigue. And again, the same philosophy applies, that we would treat those symptoms as best as possible while continuing with the treatment, assuming things are, again, mild or grade 1. So again, on patients with combination immunotherapy and TKI, if the symptoms persist or worsen, holding the treatment does give us a lot of information. You have to keep in mind the half-life of the different medications that you're giving. And so the half-life of axitinib is approximately 6 hours, so it does clear the system pretty quickly. Cabozantinib, the half-life is longer. It's 55 to 99 hours, so it may take longer for symptoms related to the cabozantinib to resolve. But it is important that if you do decide that a symptom is significant enough that you need to hold the TKI, to follow up with the patient. And so that can be done via a variety of different methods, via a simple quick phone call. They can send us a message via patient portal. We could even do an in-person visit, or these days we can do telehealth visits and follow up with the patient to determine the next steps. If you hold the TKI because of a side effect that the patient's having and you don't see improvement in their symptoms, really that suggests that the side effect is probably more immune-mediated in nature. And so that leads us to the next slide, which tells us that, again, there is some variability in how we manage immune-mediated side effects, but there are some things that don't change. And what doesn't change is what Dr. Wolf Birchfield said previously, is that we do use the CTCAE guidelines to help determine the severity of a side effect. We don't just wing it and oh, I think I'll do this. We use the criteria that the trials and the guidelines used. So using the ASCO guidelines, the Society for Immunotherapy of Cancer Treatment, and NCCN guidelines to help determine the next steps. They have it all laid out for you there, and just following them is important. It is important that if symptoms are mild to moderate, we have some leeway in how we manage it. But if a patient has severe side effects, as indicated on the next slide, it is important that you just empirically start treatment and treat it as being immune mediated in nature, even if they're on a TKI in combination with the immunotherapy. So for severe side effects, high risk side effects that if you don't treat could become rapidly dangerous, again, you treat as if they are immune related. And so that would include pneumonitis, myocarditis, hepatitis, encephalitis, grade 3 or grade 4 colitis, or any other grade 4 symptom that the patient may experience. And so while you start the treatment or you start the patient on empiric treatment for immune mediated side effects, you still do other workups. So if you're worried about a patient having, let's say, immune mediated myocarditis, you would still be checking a BNP, checking a troponin, and maybe even doing an endomyocardial biopsy if you, again, are thinking myocarditis while starting them on steroids to treat the immune-mediated side effect.
And that's also really important. I know in colitis, we see that too, that even if we're pretty darn sure, sometimes we still really need that colonoscopy to be done in order for insurance to even cover next level treatments that they could need. We're hoping they don't, of course, but I think that's important to emphasize, just that, even if we're going to do empiric treatment, if there is testing that can help cement that as the etiology, or that unfortunately, our payers may require, it's good to proceed with that, especially because sometimes these interventions or these steroid courses could be months long. So before we commit someone to months on treatment and permanent discontinuation of immunotherapy, we want to see if we can get that data, even if they're on steroids already.
Yeah, thank you, Dr. Wolf-Birchfield. And kind of along, dovetailing on what Dr. Wolf-Birchfield said, you always do want to keep your differential broad. So just because a patient is on immunotherapy and a TKI and they present with diarrhea, doesn't mean that they couldn't get food poisoning, that they couldn't have C. difficile. And so again, you have to take the time every time to do a thorough history and communicate with your patients. It's going to pay off in the long run. Again, these patients still get infections, have heart attacks because of underlying heart disease that may be undiagnosed. They could have a rash secondary to something they came in contact with, or insect bites, or a pulmonary embolism, and not necessarily just pneumonitis related to their immunotherapy. So again, keep your differential broad. And then finally, if a patient's just on immunotherapy, the workup there is probably a little bit simpler, and it basically just revolves around using the CTCAE grading system of their side effect, and then following the appropriate guidelines. And so having those guidelines pulled up and then having NCCN guidelines there, it really just walks you through what needs to be done. And so again, I'll let Dr. Wolf-Birchfield take over and show you these CTCAE guidelines.
Sure. So CTCAE, as we said, is for basically any lab abnormality symptom that a patient can experience while in any form of cancer treatment, or even from cancer. In any case, so for Ms. Y, if we look at CTCAE criteria, then she would have grade 3 diarrhea here, as we see. And then, there are some really helpful data, and it's actually in an article specific to axitinib plus a checkpoint inhibitor, although this would apply to any tyrosine kinase inhibitor plus an immunotherapy agent, of course, which we're doing some, in other malignancies as well. Liver cancer, probably thyroid cancer is coming, in order to figure out exactly what to do. So this sort of algorithm is really helpful. So for this grade 3 circumstance, we would hold both agents immediately. If this patient does not improve immediately, then this is somebody who we believe we would also start empiric steroids for if we are not able to see improvement pretty quickly after this medication. They do make the point here that someone who has grade 3 diarrhea can usually be rechallenged, I think that's a funny word, on both of their agents if we determine that it is from axitinib. But certainly if it's grade 4, then we would absolutely discontinue their immunotherapy permanently. And this is just part of how we're all working through these sorts of situations. In the case of Ms. Z, she also has grade 3 diarrhea. In this case, unless she is withholding information about a different potential cause, we can assume that this is going to be immune therapy related. And therefore, in that case, we would go, this is an example of the NCCN guidelines, and these are kind of these shared guidelines from these different societies. But in looking at the workup, and I don't know, Katie, if on the next slide, the grade 3 component is there. Oh, well, I guess that didn't transfer over. We can update that before we put it on in the toolbox. But in any case, the guidelines would show how to manage it under different circumstances. The grade 3-4 has its own little directions that fell off the slide, but in this case, it will include empiric steroids at 1 milligram per kilogram per day of prednisone, or the equivalent dose of a different steroid of 1 milligram per kilogram of prednisone per day. And then if someone has immediate resolution, then often our practice at KU is not necessarily to push for a colonoscopy, but if it is persisting, then that individual is going to be someone who we want to get a colonoscopy. Typically folks with grade 3 diarrhea are often going to need hospitalization for supportive care and close monitoring. And certainly with grade 4, which is that very severe category, those folks are going to warrant hospitalization from the beginning. And another point that, we certainly want to make is, while we're working up things and while we're treating them, we want to make sure to be providing the very best supportive care. Some people with colitis end up with terrible nausea, anorexia, and dehydration. So we want to make sure that we're doing all of those at the same time. And sometimes those simply cannot be accomplished outside the hospital with the severity of patient symptoms. So in summary, generally speaking, if someone's on a tyrosine kinase inhibitor and immune therapy agent, if it's too difficult to attribute their symptom because we can't tell which one it came from, hold both agents. That's fine. And that will give you a lot of information. If it resolves quickly, it was probably from the tyrosine kinase inhibitor, because we will see that there is dose-related side effects that we can see there, and therefore they versus immune therapy, which would need intervention. We're often able to restart the tyrosine kinase inhibitor at the next lowest dosing level once their symptoms have resolved or improved to a mild level. If it doesn't resolve or it gets worse, it's going to be immunotherapy, and then just get back to those guidelines and follow those algorithms to the letter. For combination immunotherapy, get their CTCAE grade and use the guidelines. That's all that's needed. And now it looks like we have a few minutes for questions. And then I know Katie also has some information about wrapping up this series, not just this presentation, but the series.
Yeah, I actually have a question. I know that, prevention is key, and we push for a lot of preventative medicine and the whole under healthcare period. I'm curious, we also know people aren't really great at prevention either. So I'm really curious how, just anecdotally, how well people respond to your education. And if you find that the extra effort you put into the education, the written materials, the electronic materials, if that actually pays off well for your patients.
Well, I'll answer, but then I'd love to hear Jennifer's impression as well. I do think it makes a difference. Personally, I think not everyone follows everything to the furthest kind of letter of the law, but I do think that at least setting the expectation that these are going to need ongoing preventive and management efforts, getting them using a moisturizer, because for example, kidney cancer is more common among men. There are some men who just, for societal reasons, have not used a moisturizer twice a day for any period of their entire life. So I do think that it makes a difference. And it also gives us something that we can at their very next visit, which is usually going to be something like 2 weeks later, we can say, how is that going with the lotion? What are your blood pressure values? And give them accountability. I think, and I think also having a support person there does reinforce it and help with accountability. That's my experience.
Yeah, I think it can be very helpful. I think it really just depends upon the patient's motivation, though. There are some patients that, we can educate them multiple times, and we do educate patients multiple times with the same, recommendations over and over. And they may never start those recommendations, but I think it just depends upon their inner drive. And some patients have that, and some patients maybe aren't as motivated to take those steps. But I do think it makes a difference whenever patients are proactive.
We do often get questions about, when patients are diagnosed with an advanced cancer, which is a terrible life event, of course, we find that patients often will say things like, well, what can I be doing? Can I eat a certain diet? Can I such and such? And because, the things they're envisioning that they can do for prevention or for well-being are what they've envisioned from the rest of their life. But if we give them things to do, then I think there's a substantial proportion of the population who will ask what they can do and are either eager enough or scared enough to try and do their very, very best.
What I hear is it's a way of empowering the patient.
Yeah,
to have
it is.
a bit of control within their
treatment.
Yeah, good.
Very much so.
Are there any other questions for Jennifer or Libby? Thank you, Tracy, for adding the website link in the chat box for all the materials and resources from our ECHO series.
Yes, thank you.
We've got a couple of minutes here just to wrap things up, and we really thank you so much, Jennifer, for being with us today. And Libby, this has been a great series. I've learned a ton, and I know that anybody else that has popped in on any of these sessions has learned a ton as well. So we thank you for all the hard work you've put into these excellent lessons. We will have some more information coming. In particular, we'll do a post-ECHO survey. That will probably come out in the next couple of weeks, and we would really encourage you to take that once you get it. It'll come via email. And then if you haven't already, and if it's pertinent to your role and your clinic, please consider completing the workflow analysis, not only just for your own edification, but for us and our project as well. We would love to get that feedback. Libby, is there anything else that you wanted to add in as far as next steps?
I don't think so. We would just really appreciate everyone please completing the post survey and the workflow analysis if possible. Mm-hmm. And we would really, we really appreciate everyone's time, attention, and participation. And we will learn a lot about our own processes and future ECHO series from your feedback. Absolutely. So that's why it's so incredibly valuable.
Yes, absolutely. And just a reminder of the CE code, it's 27 torn. Did I say 72 earlier, or did I just skip the 27 altogether?
Yeah, you said 72.
Not shocked. 27 torn. And again, the due date is August 19th. And just like what Tracy put up in the chat box, the link to the Masonic Cancer Alliance website where these enduring materials live. We thank you so much for your time today. And we look forward to the next ECHO. Just stay tuned to MCA's postings because there's so many things going on and lots of learning opportunities. So anything else? Any last comments, snide remarks? No, I could come up with my own.
Thank you so much, Katie. I really appreciate it. And I hope all of you have a wonderful end to your week and a wonderful weekend.
Same to
Thank
you.
you, Dr.
Thank you.
Bye-bye.
Bye.
Thanks. Bye.